All right, so let's make another video on how to do an examination using Chirotouch. It is one of the easiest programs out there for chiropractors. It is probably the industry standard for EHR. And when we start off, we're going to use the exam button. So we're going to hit an exam, and we're going to say that we're doing an initial examination on a patient. Boom. And then from there, we're going to put down today's date. And let's say this person only has one complaint. So we're going to go to complaint and hit next and go ahead and go to the complaint section. So here we're going to ask the patient under complaints with how many days per week. We'll give him his first name. And let's go ahead and say that he has a complaint of pain in the neck. And we're going to rate his neck pain about a 4. And we're going to say that it's tight and it's stiff and he's having the pain about 3 days per week. And then from there, we can go ahead and confirm that he's not having any radiating pain going down his arms. And that's pretty much it. We'll go to etiology. When did this happen? I'm not really sure when it happened. So we'll put down today's date for this condition that it's unknown and that today's date is an estimate. And from there, we can go ahead and confirm that he hasn't had any falls, trips, slips, or accidents, or any motor vehicle accidents. And we go right into aggravating factors, things that make it worse and things that make it better for palliative. From there, we're going to say that standing doesn't really bother his neck and that walking doesn't bother his neck, but he has some neck pain when he sits, and that's after about 15 minutes. We can then also say that bending over doesn't bother him, and if there's anything else that bothers him, we can add it by simply hitting the speaker button. The patient stated that he notices neck pain when turning his head right and left when driving, period. And we can save that. From there, we can ask, was there anything you do that makes it feel better? Yeah, I've used BioFreeze, I changed my position, I've tried heat, and I've taken ibuprofen. From there, we can ask the patient any other conditions that may have improved it, and if not, we go right under his past medical history. Under past medical history, we can deny having any broken bones. We could say that he's not had any surgeries, and under trauma, the patient stated that they had a motor vehicle accident about 6 years ago, period. They had neck pain related to this accident, period. They treated with a chiropractor, period. So from there, we have his past medical history. It's not a female, so we're not going to ask about children. And then we're going to go right under, I see a lot of elderly patients. I always try to ask if the person has a pacemaker. If it applies, put it down. I'm going to skip this question for this person. They're young. General health looks pretty good. No heart disease, cancer, stroke, or diabetes. So I'm going to put down uneventful. And from there, we're going to go right into, again, not female, so we're not going to ask about whether they're pregnant or expecting. Then we'll go right into the review of systems. From here under the review of systems, since this is initial examination, we're going to ask them whether they wear glasses or not. So we're going to say no for glasses, and we're going to say no for hearing problems, no problems with smells. We're going to go right into any digestive issues. They do have occasional constipation, put down occasional, and then the person also denies having any hernias. From there, we can put down breathing issues or none. We can say that they have no chest pains or heart palpitations. And we can deny any problem with diabetes or any other endocrine issues. From there, they have no skin issues. And they do have a little bit of occasional anxiety, but they're not on any medication. From there, again, not a female and too young to ask about prostate issues. So we're going to skip that for now. From there, we go over family history. And they do have a family history. Oops, let's go back. Family history. The person does have a family history of diabetes. We'll just check off diabetes right there. And from there, we can say that under personal social, that the person does not drink any alcohol, they do not smoke cigarettes, and they do a cup of coffee a day. So I'll do a cup of coffee a day. Under their employment history, we can say that the person is, whatever. The person is employed as a police officer. And over here, under their primary medical doctor, we can say that the person doesn't have a primary. All right, beautiful. From there, your subjective findings are done. So that moves right into the exam. I mean, the objective findings are very simple. You go under exam, and I'm not going to really talk about the person's gait today, but if they had a wheelchair or a walker, I definitely would be adding that. So I'm going to go right to vitals. From vitals, we can say that the person is 5 foot 5 inches and that they weigh 180 pounds and that their blood pressure is 120 over 80 and their pulse is 80, respiratory rate is 16, and we can say that they are 97.6 degrees. All right. From there, we go over visual range of motion, and since we're talking the neck, we're going to click the neck button. From there, we can ask the person to turn their head forward and backwards, right and left. They have no problem with flexion, but they're very restricted going in their extension. They have mild restriction going to the right with lateral flexion as well as the left, but they really have no problem turning their head to the right, but moderate restriction turning their head to the left. From there, we can say that the person had pain, again, when he turned his head to the right, to the left, and with extension. From there, we do reflexes. Again, all of his reflexes were normal, so we're going to just check off the normal button for the upper extremities, and that takes us right into our orthopedics. For the orthopedic test, we can say that with a single complaint, we are going to have the cervical orthopedics on top. We're going to say foraminal compression was negative, cervical distraction reduced pain in the neck, and that shoulder depressor was negative 2. That takes us right to the leg checks or to cervical syndrome. Positive cervical syndrome is going to be found on the left. And he also takes us to our palpation findings. With palpation, we can say that the person has tenderness at C1 and C2, 1 and 2, and they also have some neck spasms going into the cervical, and I'm going to make these things right here be the trapezius muscles, so into the right and left traps. From there, we can ask the patient if they've had any x-rays. They've not had any x-rays, so we're going to send the patient out for some x-rays. And why we're going to send him out for x-rays? He has a history of past trauma. He has, I want to see the structures. I want to see the alignment. He has some decreased range of motion, and that's enough for the rationale. We're just going to do a minimal cervical view, 2 to 3 views. From there, our objective findings are done. We go right to our assessment. Under examination for assessment, we're going to do a diagnosis. We'll start with segmental dysfunctions and all those other choices we can add on whether they had sprains or strains or non-subluxation issues. But from now, we're working with C1, C2, C5, C6, and let's say throw in T1 for good measure. So from there, that causes pain in the neck with cervical syndrome, both occiput C1 as well as the rest of the cervical spine, and we can throw in the thoracic that we're working with segmental dysfunction. From there, we go right into the patient's status. Their status is acute, and this is their initial exam. So we'll take off initial. We can remove that button later on. Let's say we do 3 or 4 visits, so get rid of that and take initial off by going like this. That doesn't take too long at all. From there, we go under status. We can go under prognosis. I'm going to say the prognosis is good. And we also have the person fill out functional outcome assessments. I like using the pain index by the American Medical Association, so I'm going to introduce the AMA one. You can also use the back or the neck index for this one. There's 1 form, so he's not doing more than 2 or 1. We do cervical. From there, let's say he scored 20 out of 150, which is on the low end of normal, but our interpretation is this person has a functional outcome assessment deficit. Bingo. From there, our assessment's done. We're going to go right into treatment plan. And for the treatment plan, I'm going to push this one right here, which is twice a week for 1 to 2 weeks with muscle stim and heat. And I'm also going to say that today's visit included an examination, a manipulation, 1 to 2 regions. We're going to do some muscle stim and heat on the individual. I'm going to give them a copy of these notes because I referred them out to x-rays, but I also want to give them some home exercises. And we also did that functional assessment there. From there, we go under our physical therapy findings. What did we do for physical therapy? Well, again, I went over muscle stim and heat for this individual. We did it for 15 minutes, and I actually did this at T3, seated with the pads on the neck, and we did this seated before his manipulation, which again leads us to the manipulation, introduce the manipulation, and we're going to do chiropractic supine positions, Gonstead. We're going to do C1 and C2 on the left, C5 on the right, and we're also going to do, let's say, some activator for the upper dorsals at T1. So there's activator, and we're going to do T1 with the activator. How did the person tolerate treatment? The guy did great, so we're going to say good. And I'm going to put a dash on this right here. And this way, if the next time I go to see him after the treatment I wanted to add something, I have that ability just to hit that dash and then add another comment to it. I want to see the patient back twice next week, so the return visit is going to say 2 times next week. And then from there, we're going to go right over our goals. Again, we want to get the person out of pain, increase their range of motion, and we want to also eliminate their functional deficits. And we're going to ask them to do ADLs on the next visit, the activities of daily living. I'll show you what that looks like in just a moment. So from there, we go under next, and we're not really having the patient be out of work, so we can skip that one, and it goes right into our specific goals. So for the cervical, he scored 20 out of the 150 for the AMA guides for the pain index, and our goal is by the next examination to see a 50% reduction in that number. Beautiful. From there, I also recommended that the patient have some exercises. Under home exercises, we can introduce the home exercises, and we can say for the cervical, we're going to recommend the exercises for neck spasms right there. Good. That's pretty much it. So if I were to look at this examination on the iPad, we would say that it's a new patient exam with a single complaint, with their etiology, their assessment, their palliative, their general history, their review of systems, their personal history, their employment. And if I look at the clock, we're at 11 minutes. So it took about 11 minutes to do this exam. And as I'm doing the exam, I'm holding the iPad, I'm talking with the patient, and we're literally pushing the buttons as fast as I went over with you. The patients do their range of motion in their neck. We check their reflexes. We ordered x-rays. We go under the diagnosis. Again, we have their segments, their segmental dysfunction, their diagnosis, their status, their prognosis, their FOAs. Oh, I mentioned if the person was going to do functional limits, we would just hit the functional limits on the next visit, ask them what their pain's interfering with. They can go down this whole list. I normally do this on the second visit, but we'll just show you what it looks like today. They have problem carrying groceries, caring for their family. They have a hard time driving for 15 minutes. They have no problems lifting, and let's just say they have a problem sitting comfortably. So when I get done with this patient, I'm going to go under here. I'm just going to double tap inside here under select all. From here, we're going to copy it, and we're going to go back to our plan. And under the return visit button, I typically keep this just like this. So I go under goals, and I go under specific goals, specific ADL goals. And for this, on today's date, we're going to recommend, based on their functional limits and their ADLs, that we want to, with chiropractic, with physical therapy, and home stretches, see an improvement with the following activities. And we're just going to paste this, and we're going to save it. But more importantly, we're going to say we want to see a change within 2 weeks. And I'm going to say that the date was set today, and 2 weeks from now would be the 19th about. So now I'm going to leave this on their chart every time I see the patient, so when the 19th comes, I'm going to know to go back and read them what their limits were and then have them fill it out again to see how much they've improved. And here's the great thing. After we're done with this examination, we can do what I call scrubbing the chart. When you scrub a chart, you're making the second visit off of the exam. And here's how you scrub a chart. You get rid of the word type of exam and eliminate everything above the chief complaint and put the words daily note. I would then get rid of days per week. I don't need days per week, and get rid of everything after etiology. So all of this, which is the exam findings, disappears. When I go to the objective findings, get rid of the x-rays, keep the palpation findings, keep the cervical syndrome, and get rid of all the orthopedics, get rid of the vitals, get rid of the range of motion, because they're not needed for today's visit. For the assessment, get rid of the functional outcome assessments and keep everything else. They're the same. For the plan, get rid of the exercises, get rid of the recommendations, get rid of the goals, keep your specific ADL goals, get rid of the specific activities, Keep the return visits because you'll be changing that. Keep what you did as far as the adjustments. Keep the physical therapy. Keep your treatment notes, what you physically did. So let's say day 2 comes along, and again, you did a muscle stim, you did adjustment, you gave him a copy of his notes so that he has a copy of it, and